Hello guys, welcome to Ankit Sunelwits. Today I'll teach you how to do perfect gynecology examination for your examination purposes. You have to take consent, stand on the right side of the patient, make sure adequate lighting is there and privacy of the patient to be maintained. If examiner is a male, then have a female attender. So we'll start with general examination. In general examination, you have to say it like patient is comfortable at rest, conscious, cooperative, oriented to time, place and person. Generally patient could be uncomfortable at rest if there is a severe form of ascites and patient is feeling breathlessness or because of any cardiac disorder or any lung disease. Build, nourishment, which will be based on BMI. You can even say patient look cachexic. Cachexic means there is a severe muscle atrophy, muscle wasting and weight loss. Like here also in this picture you can see this patient look cachexic. Cachexic look would be there in ovarian and cervical carcinoma. Then you have to calculate her BMI based on her weight and height. In this, obesity is most important. Generally according to ICM, more than 25 BMI is obese. Obesity, what happens? It increases the estrogen. As fat converts androstenedione to estrogen at higher rate, so in body estrogen is increasing, so estrogen exposure is increased, then there is a risk of fibroid and endocervical carcinoma. Pallor could be there in bleeding or fibroid disorders. Icterus could be there in late stage of ovarian carcinoma when ovarian carcinoma have metastasized to the liver. Cyanosis could be there in cardiac or liver disease. Clubbing, generalized lymphadenopathy. You have to look for cervical lymph nodes, especially if there is a tuberculosis in the patient, or supraclavicular lymph node, especially the left supraclavicular lymph node, which is also known as Virchow's lymph node. It could be enlarged in ovarian or GI malignancy. Then you have to look for inguinal or pelvic lymph node for staging purposes. If the cancer have metastasized, then it can result into obstruction of lymphatics and it can cause DVT also. Then in vitals, you have to look for BP, pulse, as tachycardia could be there in fever, infection, salpingitis, appendicitis, ovarian torsion and thyrotoxicosis. Then respiratory rate could be increase in anemia also, temperature and her SpO2. Then you have to look any features of connective tissue disorder like SLE or Marfan syndrome, because as uterine prolapse is common in patient with connective tissue disorders. If the patient gave history of amenorrhea, then to look for Turner syndrome features like pigeon chest, webbing of neck, cubitus valgus. Features of hyperandrogenism, you have to look like hirsutism or acne or any voice change from high pitch to low pitch, because polycystic ovarian disease is a risk factor for endometrial carcinoma. Then you have to look for her hydration status at tongue. If the tongue looks dry, it means hydration is poor. Could be because of malignancy, abdominal mass, or patient is going for chemo or radiotherapy. Signs of malnutrition, so you have to look. Then in other system examination, you have to examine CVS for any mitral valve prolapse. In Marfan syndrome, Turner syndrome, people can have coarctation of aorta. Then you have to examine respiratory system. If there is a tumor metastasis to the lung, then it can result to pleural effusion, or if any underlying pathology which is causing cough, because cough can aggravate uterine prolapse. Then you have to examine breast. Breast is very important to examine because breast carcinoma is second most common malignancy in females after the cervical carcinoma. Then you have to look for thyroid. If the patient has spina bifida, then the patient is prone for your prolapse. Spine examination is also important as it is the reason where anesthesia would be given, so we have to check. There are 9 quadrants in the abdomen. With that, we have to examine supraclavicular area, renal angle, perineum and genitalia. These all areas comes under abdominal examination. So in abdominal examination, bladder have to be emptied. If the patient gave history of stress urinary incompetence, then you have to first examine her for stress urinary incompetence with a full bladder. Then you have to look whether abdomen is distended or non-distended or in normal shape. If abdomen is uniformly distended and flanks are full, it means mostly it is ascites. If you can see any mass, then you have to tell a mass is visible in this quadrant or this region. Like uterine mass would be a midline mass, a ovarian mass would be toward right iliac fossa or left iliac fossa. Then you have to see whether all the quadrants move equally with respiration or not, because the quadrant having pathology will not move much with the respiration. If there is an inflammation in the side, there would be reduced movement, like especially in peritonitis, the abdominal movements would be reduced. Then you have to talk about umbilicus position. Generally, If there is a pathology below umbilicus, then umbilicus will move upward. If the pathology on the right side, then the umbilicus will move toward the left. Umbilicus would be flush to the skin or everted in case of ascites. Then you have to look for any scar, especially a hysterectomy or incision scar, because these scar can result into incisional hernia also. Any visible pulsation in gauze vein. Hernial orifices you have to look. Then you have to look for any renal angle fullness or supraclavicular fullness. If there is any mass per abdomen seen, then you have to talk about its site, its size, its extent, its shape, its margins, regular or irregular, all the margins seen or well or not. Because a uterine mass, lower margins won't be seen, but in ovarian mass, all the margins mostly would be seen. Surface appears smooth or irregular. Does it move with respiration or not? For differential diagnosis for mass for abdomen, upper abdomen it could be of ovarian carcinoma, secondaries could be there present as omental cake. In hypogastric region it could be uterine enlargement or urinary bladder carcinoma or full urinary bladder. In right iliac fossa it could be ovarian tumor or appendicular lump. In left iliac fossa it could be left ovarian mass. So moving on with palpation of abdomen, make sure you rub your hands and warm them before you palpate. You have to look for local warmth and tenderness. Suprapubic tenderness could be there in case of cystitis. You have to look for any rigidity or guarding in the abdomen, as generalized guarding could be there in peritonitis. Any localized rigidity could be there in ovarian cyst or ectopic pregnancy or appendicitis. Then you have to palpate for liver and spleen. How many centimeters they have extended from mid-clavicular line, what are their edges, consistency soft or firm or hard, what is the surface, are they tender or not. In spleen you have to mention whether the splenic notch was palpable or not. In liver, if there is a secondary metastasis from ovarian malignancy, liver will have nodular surface with sharp edge and non-tender. Then you have to palpate at renal angle for any tenderness or any supraclavicular lymph node is palpable or not. You have to palpate that. If any mass is there, then you have to look for any tenderness over the mass. Already mass per abdomen you have mentioned in inspection. Now in palpation you have to say site and extent and size and shape was confirmed with palpation. Then to look all the margins for palpable or not. Generally lower margins won't be palpable in case of fibroid or a uterine mass. As in ovarian mass it have long pedicle, so all generally lower margin and all the margins would be nicely palpable. Then to look whether surface is nodular, lobulous, smooth or irregular. Consistency, mobility, whether the mass is mobile in horizontal direction or in vertical direction, plane of the swelling. Generally if it is attached to skin, then the skin won't be pinchable above the swelling. If the mass is above umbilicus, then you can tell the patient to raise her head. If the mass is below umbilicus, you can tell the patient to raise her legs. If the mass is on the flank side, you can tell the patient to do Valsalva manual. If the mass become prominent, it means the mass is parietal. If the mass do not become prominent on raising head or limbs or doing Valsalva maneuver, it means the mass is intraperitoneal. To differentiate between intra and retroperitoneal, what was done was knee and elbow position. And this patient would be lying on her knee and elbow, and then you can see if the mass falls forward, then mostly it is intraperitoneal. Retroperitoneal masses would not fall. Most of the examiner do not prefer this examination. So now instead of doing knee elbow position for the patient, what you can do is, if the mass is there on the left side of the patient, you tell the patient to move to the left lateral position, extreme left lateral position, and then you see whether this mass comes forward or not. This is how you can differentiate intra and retroperitoneal. If the mass is pulsatile, then it could be because of some aortic aneurysm. Then you have to do percussion. If the dullness is there in the flanks and it is present with shifting dullness, it means free fluid is there. Free fluid could be because of ascites, because of liver secondary, or any ruptured ectopic or hemorrhage. Generally, percussion over the mass will reveal dullness there, and there would be no shifting dullness if there is no fluid. But intestinal obstruction or retroperitoneal tumor could be resonant, as intestine would be above them, which will result into resonant sound over the tumor. Then uterine masses generally would be in midline, but they will be mobile only in horizontal direction. In ovarian mass would be mobile in all the direction, but this mobility could be affected in case of torsion or any malignancy is there, so it can become fixed. Generally, encysted tuberculosis is mistaken for ovarian malignancy. The only thing is it would be immobile and be resonant to percussion, due to surrounding bowel loops. If there is any mesenteric cyst, like root of the mesentery would be like this, 6 centimeter in length. So if there is mesenteric cyst, then it will be mobile only in 90° to the line of its attachment. If any tubo-ovarian mass is there due to endometriosis, then patient may give history of PID. Then generally mass would be firm to tender and would be close to uterus. If any appendicular mass is there, then patient will give typical history of fever, abdomen pain, vomiting. There would be signs like rebound tenderness in the right iliac fossa. If you compress the left iliac fossa, then pain would be felt on the right iliac fossa. Ileocecal mass generally due to tuberculosis or cancer would be fixed to the right iliac fossa mass. So ovarian mass also you can differentiate whether it is a benign or a malignant. If the size is generally less than 8 centimeter, it's benign and it be smooth, regular, well defined, freely mobile. But if it is a malignant ovarian mass, then it could be larger, rapidly growing, it be adherent or fixed, mobility would be reduced. Mostly in mass per abdomen, you have to differentiate between adenomyosis, fibroid or ovarian. Generally, you can differentiate with their history. On examination, adenomyosis would be tender, uniformly distended, but a fibroid will be harder compared to the normal uterus. It be irregularly distended and a midline mass. In ovarian malignancy, it be freely mobile in horizontal and vertical direction. Patient may have history of jaundice, ascites. Then coming to the auscultation, in auscultation to hear bowel sounds, a bruit could be heard over highly vascular tumor or fibroid. Uterine bruit could be heard if woman is pregnant. Generally, these bruit will sync with the radial pulse. If there is a hypoactive bowel sound or no bowel sound, it could be because of paralytic ileus, which could be secondary to the peritonitis. Then coming to pelvic examination, make sure before examining any minor or unmarried female, you have to take consent from her parent or guardian. Do not do pervaginal examination or any speculum examination in unmarried females. Generally, for pelvic examination, this dorsal position is preferred. For pelvic examination, again you have to start with inspection. Pubic hair, vulva, perineum or thigh, any scratch mark or any ulcer, because these could be there in if the patient is having sexually transmitted disease. Then you have to separate the labia using your left hand fingers and look for any discharge at urethral meatus. Then you have to look at her external genitalia. If any atrophy would be there, if the patient is of old age. If there is no development, then it could be because of hypogonadism. Clitoris, generally the size would be less than 1.5 centimeter. If the clitoris size is more than 2 centimeter, it could be called as clitoromegaly. The most common cause for clitoromegaly is congenital adrenal hyperplasia. Then you have to look at her vagina, at her introitus, at her hymen, whether there is any discharge, whether the introitus is of gaping. Normal introitus would be of V shape, but if it is of gaping, then it would be of U shaped. In case of imperforate hymen, you will see bulging, shining and bluish color of hymen. Then you have to examine her perineum, look at the anus for any fissure, fistula or any hemorrhoids, any signs of perineal tear is there or not. As I mentioned before, if the patient gives history of stress urinary incontinence, then you have to examine her with full bladder for Bonney's test. Patient have to be in full bladder. Tell her to strain and look if there is any urine dribbling from a urinary meatus. If urine dribbling is present, it means stress urinary incontinence is present. Then in Bonney's test, you have to put your index finger and middle finger inside the vagina and lift the bladder neck. Then you tell the patient to again strain and look for any dribbling of urine. If there is no dribbling, it means Bonney's test is positive, and Kelly's plication in the surgery will be useful to treat stress urinary incontinence. If the dribbling is still there after pushing back the neck of bladder, it means Bonney's test is negative. Then the patient have to undergo some sling surgeries. One viva question would be like, what are the another contributions of Bonney? Bonney was a surgeon who removed maximum fibroid from the single uterus. He have derived this Bonney's test for stress urinary incontinence. There is a Bonney hood operation, myomectomy for fibroid, where Bonney's clamp and Bonney's screw is used. For inspection of mass per vaginum, you must know what are the basics of prolapse. First, in this you have to know like if there is any descent from the upper anterior 2/3 vaginal wall, it could be because of descent of bladder, which would be known as cystocele. If there is a descent of urethra in the lower 1/3 of the anterior vaginal, it could be called as urethrocoele. If both are there, then it is called as cystourethrocoele. In the posterior vaginal wall, if there is a descent of small intestine from the upper 1/3 part of the posterior vaginal wall, it could be called as enterocoele. If there is descent of rectum in the middle 1/3, could be as rectocoele. Lower third could be called as deficient perineum. With deficient perineum, we will get to know whether a perineal repair is required or not. If the uterus have already removed, then the post hysterectomy patient may have walled prolapse, where the wall can prolapse. There is Shaw's classification for the prolapse. If there is first degree of prolapse, then cervix will be below ischial spine. If the cervix is at the level of introitus, then it is second degree prolapse. If the cervix is outside the introitus, then it means it is third degree of prolapse. If the uterine fundus is outside the introitus, then it is called as prosidentia. So on mass per vaginum, on inspection, you have to look how many centimeters the mass is outside the introitus. Then you have to look whether cervix is visible or not. Generally, if it is a walled prolapse, then cervix won't be visible. Bulge would be there in uterovaginal prolapse. Bulge won't be there in congenital elongation of cervix. Then to look for sulci. If there is any mass or any bulge between submeatal and transverse vaginal sulci in the anterior vaginal wall, then it would be mostly called as urethrocoele. If there is any mass or bulge after transverse vaginal sulci, then it would be cystocele. Like for example, so this is the transverse sulci and the mass is above the transverse sulci, so this is cystocele. Here you can see this is the transverse sulci and this is the urethral meatus sulci. The mass is between them, so this is urethrocoele. Antero and rectocoele would be there in the posterior vaginal wall. Like here, if there is a descent of intestine, it would be a enterocoele. If there is a descent of a rectum, it would be called as rectocoele. So after noticing bulge and sulci, you have to look whether vaginal rugae are present or not. What is the size change on cuffing and straining and Valsalva maneuver, whether it's increase or remains constant, whether there is any ulcer over the mass descending per vaginum or not, or there is any discharge or any congestion or edema. Hyperpigmentation could be there. If there is a old prolapse or a very chronic prolapse is there, then it can result into hyperpigmentation over the mass. The ulcer which would be present generally would be of decubitus ulcer, which would be a trophic ulcer. So the H would be sloping and it will heal with crystalline package. If there is a squamous cell carcinoma of vagina or any cervix, so then the margins would be rolled out and everted margins. This is how you differentiate between a decubitus ulcer and squamous cell carcinoma ulcer. Then you have to come for speculum examination. There are two types of speculum, Sims speculum and Cusco speculum. Generally you would be getting prolapse case in exam, so you would be using Sims speculum for it. So here are the contributions of Sir James Marion Sim. Sims position, a left lateral position, Sims speculum, Sims triad. Actually, he is known as the father of vesico-vaginal fistula repair, as he used silver wire for suturing it. So the question comes, why to do speculum examination before manual examination? You can do cervical scrape cytology and endocervical sampling in the same sitting. It could be used as a screening. And also if there is any discharge, you can take for bacteriological examination. If you do manual examination before, then that may result into bleeding. Then thereafter it will be very difficult to examine cervix. So for speculum examination, first you have to look at vagina. Vagina would be atrophied and loss of rugosity would be there. It would be dry in case of menopausal woman. It would be generally normal color of the vagina would be pink with presence of rugae. Look if there is any discharge or any growth or any ulcer in the vagina. Look if the cervix look healthy or not. How is the os? Is there any laceration, ulcer or any discharge? Generally in case of cervical carcinoma, there would be ulcerative, fungating, friable growth which would be fixed, indurated and bleed on touch. If there is any cervical erosion, then the cervix will appear velvety. If the cervix looks strawberry, it would be because of punctate hemorrhages. Then it could be because of trichomonal infection. Then you have to grade urethrocoele and cystocele. In this, what you have to do is, in the grading you have to do based on Shaw's classification. You have to first reduce the mass to the normal position. Then you put a speculum in the anterior vaginal wall and tell the patient to strain. While the patient is straining, slowly you remove your speculum and notice which side of the vaginal wall is bulging. If the bulge is coming from the upper anterior vaginal wall, it is cystocele, If the bulge is there in the lower vaginal wall, it is urethrocoele. The same way you do for grading of rectocoele and enterocoele, you reduce the mass, you put a speculum in the posterior vaginal wall, and slowly you remove your speculum out from the vagina and look whether the mass is coming from the upper posterior vaginal wall, it is enterocoele. Coming from the lower posterior vaginal wall, it is rectocoele. Then you have to do digital examination. Make sure you have sterile glove. You must use lubricant. Palpate if there is any swelling like Bartholin ductosis. Generally, Bartholin glands won't be palpable unless it is inflamed. You have to compress at the urethra from upward to downward direction. Look if any discharge is there. You have to palpate vaginal wall, palpate vaginal fornices, whether they are bulky, tender, or they are shallow or deep, or else they are free or normal. In digital palpation, you have to feel for the direction of cervix. Generally, in normal women, uterus would be anteverted and anti-flexed. So when you do digital examination, you can feel the cervix direction, which would be backward and downward, and the anterior lip of the uterus would be palpated first. So it means uterus position is anteverted. If the uterus is retroverted, then you will feel the posterior lip first, and the os direction would be like upward and forward. Why it is important to know is retroverted uterus could be there because of developmental anomaly, because there is lack of tone in uterine muscle. It could be acquired, like during perpudial time there is a ligament stretching in the childbirth that can also result to retroverted uterus. And retroverted uterus are more prone for prolapse. Retroverted uterus there could be because of fibroid on the anterior or posterior wall. Then you have to look at what station is the cervix. Generally it would be at the level of ischial spine. In non-pregnant women, consistency would be firm. It will feel like as if you are touching your tip of your nose. Shape would be conical with smooth surface in nulliparous women, but would be cylindrical in case of parous women. Then you have to look for external os. External os would be smooth and round in nulliparous, but would be dilated with evidence of tear in parous women. Then you have to look whether there is any cervical tenderness or not. On gentle moving your fingers at the cervical os, there could be yelling tenderness, which could be there in acute salpingitis or ectopic pregnancy. Palpate for any growth in the cervix which is bleeding on touch, mostly cervical carcinoma. If there is a blood on examining finger, then you have to think that the lesion is at cervix or at vagina, which is resulting blood in the examining finger. In the palpation, you have to palpate for the perineal body. You have to put one finger inside vagina and thumb outside. With that, in between that, you have to palpate for perineal body. You have to look for the tone of levator ani. Put your index finger inside the vagina and tell the patient to contract her pelvis. Then you have to palpate the muscle between vaginal finger and thumb. Then you have to measure perineal body length. Normally it would be 2 to 4 centimeter. If there is any mass is there per vaginum, then you have to see can you get above the mass or not. Here on the anterior side, you have to put your thumb and your index finger and other fingers on the posterior side behind the mass. Then you have to see whether your fingers and thumb can be approximated at the fundus or not. If it could be approximated, then mostly it is procedentia. So there are 7 differential diagnoses for mass descending per vagina. First is congenital elongation of cervix, which would be a cylindrical mass, no bulge. Fornices would be deep. They will generally present after 30 years or after their marriage. Uterus size would be normal. The second diagnosis is Gardner's cyst, where there will be no sulci, no rugosity. It will be irreducible with pressure, it would be tense and well defined. Vaginal cystocele, where sulci would be present, it would be reducible mass, fibroid polyp. It will look ulcerated or infiltrated, shaggy mass, irregular mass. Also around the mass, you can feel the cervical lips. Next is prolapse, which will reduce by lying down, aggravate on cuff and abdominal stress. Bulge would be there, fornices would be shallow. If there is chronic inversion of uterus, generally it would be there because of fundal fibroid. Then the mass would be irreducible. It won't aggravate with cuff, but uterine cavity would be shortened and fundus would not be palpable. In vault prolapse, there would be always a history of hysterectomy. There would be a globular mass and you can see a scar of hysterectomy. Cervix won't be visible in vault prolapse. On bimanual examination, you have to examine with index and your middle finger. Here you have to palpate for uterus, for uterine appendages, and for pouch of Douglas. In this, you have to palpate for uterus. You have to tell what is the position of uterus, anteverted or retroverted. If the uterus is anteverted, with your left hand when you push downward, you can palpate the uterus between your right and left hand. If the uterus is retroverted, you won't be able to feel the uterus between your right and left hand. Retroverted uterus are prone for prolapse. The uterus could be enlarged and irregular in case of fibroid. Uterus size could be enlarged in case of pregnancy, adenomyosis, or any cystic enlargement with pyometra, or during fibroid. Uterus consistency could be soft in case of pregnancy. Uterus would be doughy in consistency in case of hereditary mole. In case of fibroid, but it could be restricted mobility in case of adenomyosis. Then you have to look for any tenderness. Uterus would be generally tender in case of adenomyosis. So uterine appendages, you have to put your vaginal fingers in the lateral fornices. Generally, normal uterine tube won't be palpable. Rarely you can palpate ovary. Look whether you can feel any adnexal mass or not. Then you have to examine for pouch of Douglas. If uterus is retroverted, then its body can be palpated. So to differentiate between uterine and adnexal or ovarian masses, like uterine mass would be in central position. If you move the cervix with your vaginal finger, then you can feel the movements in the abdomen or vice versa. So this is called transmitted mobility. Transmitted mobility would be there only in your uterine mass, and uterine mass generally per abdomen will be mobile in horizontal direction, and menstrual cycle would be normal. Where in adnexal or ovarian mass would be generally lateral. There would be no transmitted mobility. Ovarian mass generally would be mobile in horizontal and vertical direction unless it is malignant or it has got adherent due to pelvic inflammatory disease. Then you have to do is rectal examination. Rectal examination is indicated in female and unmarried child where you cannot do per vaginum examination. Other indication is when you want to know the involvement of broad and uterosacral ligament in case of rectum, cervical carcinoma, where you want to palpate pouch of Douglas. And it is also very important in case of cervical and ovarian malignancy, and also to differentiate between rectocele and intercele. And in case of all the acute abdomen case, it will be incomplete if you don't do rectal examination. Like you can palpate for any pus or any blood in the pouch of Douglas in case of ruptured ectopic or pelvic abscess. So you can feel for any nodules in pouch of Douglas in case of ovarian or cervical malignancy. If you have to put your one finger inside the rectum. Here, if there is, you have to ask the patient to strain. If there is a prolapse, then you can feel any shallowness or any pouch formation. Then you reduce the vaginal mass. If it is a rectocele, then you can feel the mass hitting on the pulp of your finger. If it is enterocele, then you will feel the mass hitting on your tip of your finger. This is how you can differentiate between rectal and enterocele in per rectum examination. Then if there is any tenderness and bulging on the anterior rectal wall, it could be because of pelvic abscess or pelvic hemorrhage. If there is tenderness on the right side of the rectal wall, then it could be because of appendicitis. There is another examination, recto-vaginal examination, where one finger will be in rectum and one finger would be in vagina. It would be there to determine the lesion between bowel and rectum, and also for any thickening or beading in uterosacral ligament or any presence of endometriotic nodules. Then you have to tell finally you have a diagnosis. 55-year-old postmenopausal woman with 3rd degree uterine prolapse, 2nd degree cystocele, 3rd degree rectocele with stress urinary incontinence. So thank you for watching this video. See you guys in my next video. Bye bye.